writing down the next prescription for, and then okay, you're done. Okay, 2 minutes out. You go. The blood pressure is taken by a nurse who's harried, and then you go and get your medicine somewhere, and that's it. Continue the same, and you see a different doctor every time. Now, is that continuity of care? Maybe it's true in a rural area where I think the polyclinics do a better job. And I'm not totally against one Malaysia clinic, okay? I mean, I know I come out in the press coming out very strongly. My idea is that if you want to have non-Malaysia clinics, by all means have it, but put a doctor there. Rather than bring the urban areas where you have lots of doctors down to the level where you don't have in the rural area. But the good MA in the rural area could be enriched further by putting a doctor there. There are a lot of problems like this that the government is not addressing. So I think we can do better. But you're absolutely right. In hospital, it's only about 25% in the private sector because the cost for admissions into the private sector is still high, unfortunately. For our current population, because our earning capacity is so low compared to the, to say Singapore and the more developed countries in this region. And that's the sad part about it. So these are actual numbers in 2008. If you want, I can let you download this. Actually, it's freely available in a lot of places. So I don't want to go through this. I just want to quickly take you through a few more things here about why we are concerned about this change. Now, WHO, if you remember, always works on population-based health more than anything else, which I think is important. We are not saying it is not. But if you look at developed countries, for example, do they actually look at the WHO as a model to follow? The answer is no, although they are increasingly thinking about it, to be fair. All right? So they want universal coverage, which every country in the world believes. I think all of us, whether we are socialists or liberals or whatever, believe that health is a right. The question is how much health or the demands. I think that's the thing. If you have, for example, a heart attack, the ideal is that you should be treated whether you're poor or not poor. Okay, and are we getting that in this country? I think in most of the urban areas or the suburban areas, I think you get a pretty good treatment. Now, contrary to what you all think, that only in the urban areas you get the best care, which I don't deny, okay? You will get the best care. Say if you have a heart attack, the best treatment nowadays is to get a direct angioplasty. You come in, that point in time, within 90 minutes, I go and put in a balloon or a stent, even if it's in the middle of the night, I open up the artery, wash away the clot, and you can go back in 3 to 4 days, which is never heard of before. And you do very well compared to someone who's doing something else. That's the ideal. Can it be done worldwide? No. Even in America, it's less than 15%. Yes, it cannot. It's too expensive, firstly, and it's too big. But certain countries can do it. Poland has done it. Czech Republic has done it because they invested a lot of money there. And their base was so low, they transformed by just simply upgrading everything. They're the only 2 countries in Europe that has done very well for this direct angioplasty. In England, it's less than about 40%. Okay? So it's getting there, but we're not getting all the way there. But what can we offer? There's an alternative called a clot buster, okay, which is that thrombolytic therapy. Now that is actually given to almost 90% of the population here, and they get it within 90 minutes as well. And the results are relatively good. So I'm saying that for certain catastrophic things, we do get that. When it comes to more elective surgery, okay, say you don't have a heart attack yet, that's where the problem is, like what Kumar has said. If I just have chest pain when I'm walking or climbing up the stairs, like this is a chest test for most of us here, then you immediately demand to be treated, all the way, or do you, wait for you to? When I was in UK with the NHS, I was working there for 4 years. I can tell you that a nice lady with a tongkat will come, from the suburb, take a train, you walk, get into the clinic to see me, and then my boss was there. And then I said, okay, you look as if you might have angina. You come back in a couple of months for the stress test or an echo. It's the same, And that's actually what is happening in the NHS. You can't jump the system. But that's what is going to happen if you nationalize healthcare. Everybody goes into a rationing scheme. You get into a triage. It's not fair, but that's the reality. But that's for elective things. You have a knee problem, okay, which a lot of people will have. More women than guys, unfortunately, or hip. What's going to happen to you is that you have to wait your turn, and then we will triage and see who is bad enough to need the more urgent. So What happens is that in England, the NHS has failed so badly that they're actually asking people in Europe, orthopedic surgeons in Europe, to do the operation for free. They fly them over and fly them back to do the operation because they just can't cope with what they have in the NHS. That is why they're trying to make it better. And we're going to follow that system. So I'm not saying, and I'm not cruel, okay? I wish everyone can get anything on demand. I think he has heard me say this so many times. But the reality in health is that you cannot. It's just like this. If I don't have much money, I can't stay in the Hilton. I will have to stay somewhere else, you know, a smaller hotel. You know, it's something like that. But this is where, you know, I think it becomes very difficult to accept for a lot of people. Should we equalize all the treatment for everybody, which I don't think is feasible at this point in time. So we are saying, and I think I totally agree with him, we should freeze all this privatization and enhance the public sector until it becomes so good and so excellent that people and the private sector will say, hey, they're doing a good job there. Why don't we, you know, have the system, we adopt the system. And in fact, this is what some of the WHO consultants say. Enhance the system, make it so good, make your hospitals and your healthcare centers excellent centers until people can buy in. For example, if you have your social health insurance, you begin with your government servants first. And if you can save costs and is efficient, then the private companies, for example, and corporations can say, okay, I want to get inside as well. I will buy in, and then more people get in. In fact, this is how in France, in Germany, in most of the Western countries, they do that. It started with the government, and everybody bought in. And then they found that it's actually a cheaper system at the end of the day. And then it gives competition. And only the luxurious care is taken care of by the private, and they are all boutique kinds of hotels or hospitals. So it becomes somewhat better. So the idea is that if you move, okay, let me take you back to the primary healthcare thing, which is actually the best system if you can. Okay, but again, it implies an evolution rather than a sudden change into a private healthcare, a primary care driven healthcare, meaning that the GPs or the family physicians will take charge. Okay, so I think that's the other thing that we need to address. Okay, let me quickly run through. It's a bit discordant, partly because I was taken a bit off the tangent from Kumar's presentation. So I'm trying to answer some of those things, just to show you why some of the government is a bit worried. See, from 2004, the private spending actually overtook public spending. Okay, and in 2008, it's about 16 and 18.9. Okay, and I think this year's budget was $16.8 billion, and we expect our private sector to be around 20 billion. So it's about 38-40 this year, roughly. Okay, so they think that that is not a very healthy sign, but unfortunately, healthcare will go up. This is our current system in 2006, where the taxation, that means the government part, comes to that 40% here, 44%. A few, only about 7-8% from insurance, and tiny bits from EPF and SOCSO. So you cannot rely on those. Okay, and the out-of-pocket, that means people who are spending out-of-pocket, is about 41%. And the question is that 44% of that total healthcare spending is only about 2.2% of the GDP, which is actually very, very low in comparison to the rest of the world. Okay? And if you look at out-of-pocket, and this is where the government keeps on telling you, you know, that the out-of-pocket is too high. Every time you have a lot of people spending a lot out of pocket, what Kumar says is correct. You have a chance for medical bankruptcies, okay? Because, you know, people will actually sell their homes or mortgage, you know, go and borrow from the bank, borrow from families or from relatives, and actually bankrupt themselves, you know. And it has happened. But it's not such a big problem, okay? I don't have time to cover that. But what we are saying is that if the government can actually increase, then it's a different thing, increase their budget for healthcare, for a start anyway, and then improve the system, it might be the way to go. So Malaysia in 2004, this is just a different bar chart looking at different countries. So what the government wants to do actually is to look at this part and say, look, if you look at high income, the government spends, you know, the out-of-pocket is only about 1/3, roughly, or even less if you can. Okay, government, sorry, is 1/3. And the out-of-pocket is only about, you know, 14 to 20%. And that sounds good. WHO thinks that this out-of-pocket should be not more than 30%, because that tends to lead to medical bankruptcies. All right? But that is not always the case, right? For example, Singapore out of pocket is about 77%, and there are very few bankruptcies from there. Okay, Vietnam, for example, is about 80-odd%. Okay, of course there are bankruptcies there. There are actually papers. Okay, I managed to find quite a few papers on that, written by Malaysians, but they are obscure journals that nobody wants to read. But it tells you that we are not so bad, because that portion of the people who are willing to pay for money is a thing called progressive. I don't know whether you understand the thing about progressivity. I think some of the economists here will understand in terms of tax treatment and all that. And it's something that we can debate. So what we are saying is that this is not really true, because the government is not putting in enough money. So it appears as if we are there. And we don't have what they call social security or social health insurance. That's why they want to increase that yellow part there, the social security, social health insurance. But again, knowing this government, taxing the people once more, getting the money into the fund, you don't know how much of it is going anywhere else, it's really a big question mark for most of us. So I think that's where our worry is. So we'd rather the government use the tax that is already available, put it in here and enhance the system. Okay, that's the thing. If you look at the social security and the government revenues together, it takes up usually around 60%, for most countries. Whereas the government, if you look at it, is only about 44-45% in our country. So we are saying that if you can, why don't we top it up? Mainly from the government. And once you hit that kind of a 7, maybe, or even 6% of the GDP, we will have enough money to actually enhance the system. Right now, you said about better wages, right? The last few years, last 5 to 6 years, they've actually increased the salaries and promotions for doctors. But that amount of increase is taken from the health budget. Earlier on, it was said to be from a different budget. Now it's all from the health budget. So they find that it's very expensive. So recently, I was just talking to you on the way up. They've decided to make the housemanship a contract now, because they don't have to re-employ you after the housemanship, because there's just too many doctors. Then they can select which MOs they want, because there's just too many housemen. Like the last 2 years, there are almost about 8,000 to 10,000 new housemen the last 2 years. It's just too many. And it's going to continue to become more and more. So this is actually what we are talking about. Are we spending a lot? No. I mean, if we compare to Argentina with the same comparable the gross national income, look at how much they are spending. We are spending the least. Of course, you can't shout about Turkey being a good health system or Mexico, but they have even better spending than us. So we are spending too little from the government perspective, if you look at it, for the whole group anyway. We actually don't fall into this graph here. The big outlier, of course, is US. It spends around, actually it's about 17% now of and yet their life expectancy is just about here. We are about 73. We are down here, and our spending is around here. So we are actually down here. Just to tell you that we are really off the charts. We don't want to talk about high income or even middle income. We have a long way to go. Okay. One other thing that I want to maybe address, and we will give some time for discussion. And this is just from the national budget. Okay, this is from the last year. It's about the same thing. So the projection is like this, about how much to restructure the healthcare. So it's actually not as far behind as what the minister has been telling you. Actually, all this has been projected. Okay, so it's actually was waiting to go. And I think if we think about the coming election, immediately after that, they will be there. Now, talking about out-of-pocket payments, this is the chart from WHO that shows that if, for example, your out-of-pocket continues to go up, then the risk for medical bankruptcies go up. What we call catastrophic illness and all that. So I think there is a genuine fear for that. And is it real for Malaysia? Actually, we have numbers for that. Actually, Malaysia has the least chance of medical bankruptcies in the whole Asia-Pacific region. And there are numbers on that. Yeah, I have papers on this I can share with you. And in fact, unfortunately, in Malaysia Insider, they did not give the numbers and the charts. But if you go to my site, it's actually there. I'll probably send it to you. So we have the least number there. Okay, then the financing proportion, the proposals is what we are most worried about, because we don't know where the money is going to go and how it's going to come down. Okay, and that's the one that you need to really think about it properly. And yes, the Tak Nak group, the one who doesn't like this group, by a different doctor group and another NGO, feel that if we go ahead with this, it's only going to worsen the health